Hi, everyone. This is Justin Vaughn, Vice President of Anesthesia Compliance, and just wanted to give you a presentation that will enable you to fulfill your compliance plan obligations of annual compliance training. And hopefully, this session will also help you with better understanding the requirements involved in documenting the anesthesia record. So our primary focus today is anesthesia documentation guidelines. While we will be looking at documentation basics, we'll also be taking a look at special types of cases that require even further focus in this area. So let's begin. The purpose of the session is that this is, as I said before, important for an effective compliance program to have these types of training sessions. Every member of the practice should have the same understanding of the key documentation guidelines and billing policies. And of course, this is a good time to get some gray areas clarified. Why the emphasis on better documentation of the record? Well, first of all, better documentation can lead to better reimbursement, whereas poor documentation can create confusion, hold up claims, and may raise questions with the payer. Remember that payers have hired or associated themselves with auditors, and they're always on the lookout for discrepancies between the claim form and the anesthesia record. Remember that the mantra of the auditor is, if it's not documented, it didn't happen. And so we'll want to make sure that we leave the auditor no place to go by enhancing our record documentation habits. And of course, finally, in this area, remember that a proven pattern of fraud can lead to negative action, especially by the government. So as we're looking at documentation of the record, let's begin with the anesthesia technique or mode of anesthesia. There are only three. A general anesthetic is when the patient loses consciousness or the ability to respond purposefully for any portion of the case, whereas a regional anesthetic is something like an epidural or spinal or nerve block. This is the primary mode of anesthesia here we're talking about when we say regional, not post-op pain blocks. And then finally, MAC, monitored anesthesia care. Now, sometimes you can have a MAC case that is planned for the operative session, but sometimes things happen during that case where you have to convert to a general. If that happens, then you'll want to mark general, not MAC, on the anesthesia record, mode of anesthesia, or anesthesia technique field or box. Sometimes it's a planned MAC case, but oftentimes when MAC is utilized, the provider will make use of propofol. And whenever propofol is used, often that leads to the patient losing consciousness, which of course is the definitional threshold of a general. So even though it's a planned MAC case, if at any point during the case the patient loses consciousness, then you need to mark general, not MAC. As far as our coding of the claim, we will have a anesthesia code that is added to the claim form that is sent in to the payer. And the way we get that anesthesia code is as follows. First, the coders will take a look at the procedure description that we are sent by way of the anesthesia record, and we'll put a surgical or CPT code down to reflect what that surgical procedure was. And then we will use the crosswalk manual that is provided that will translate that surgical CPT code into an anesthesia ASA code. And it's the ASA code that actually winds up on the claim form. These ASA codes are associated with various levels of financial worth or value called base units. Some may be worth 3 base units, some may be worth 25 base units, and everything in between. So depending on the acuity of the case, an anesthesia service as represented by its code will be worth more or less money. So it's important that we get the code correct so that you don't lose out on potential revenue. Now, for the most part, there's a one-to-one correspondence between the surgical CPT code and the ASA code that we can map that to. But sometimes, depending on what happened in the case and depending on what you document or don't document, there may be more than one ASA code options. So it helps for you to give us clearer and more complete documentation that will allow us to choose the correct of the optional ASA codes. Let me show you what I mean. If you've listed nothing but cabbage times 4, that may be a with pump case or it may be a without pump case. If you're using a pump, you're doing less work, and so the ASA has determined through its relative value guide that that code is worth less money than a without pump case where you're actually doing a little bit more work. So it's good to denote along with cabbage times 4 whether or not it was a with pump case or a without pump case. If it's a thoracic case and involved one lung ventilation, that's actually going to get you a higher paying code. So you'll want to include the further descriptor in the procedure box of the record, one lung vent or OLV, something to give the coders a heads up that this is a higher paying code that we're talking about. If you're doing a spinal fusion, that's one code, but if it involved any kind of instrumentation, it's going to be a code that will get you 3 additional base units. But unless you add the word instrumentation or plate or rod or what have you, then the coder is not going to know to give you the higher paying code. With abdominal procedures, we ask that you add the further descriptor upper or lower because there are 2 anesthesia codes involving most abdominal procedures. One is worth 1 base unit more than the other, so it helps us to further clarify which code is appropriate by you telling us whether or not it was an upper or lower abdominal procedure. Here we're not talking about the incision point, but rather where the actual internal surgical work was being done. Was it above the umbilicus or below? And then a final example would be a situation where the surgeon will go in with a diagnostic scope, let's say a knee scope or a shoulder scope. And once they're in there, they may find something that they can fix during that same surgical session. If so, that diagnostic scope worth 3 base units will now become a surgical scope worth 4 base units. But unless you list the surgical component like meniscectomy or chondroplasty, then we're not going to know to give you the higher paying code. So there are many examples such as these that I've just mentioned that can be found in our reference guide, the link for which you see below on this slide. I would encourage you to go and take a look at these and familiarize yourself with these several examples that will help us in making sure you get the most money to which you are entitled through the further documentation of these various components that may help you get to a higher paying code. When it comes to diagnosis, which is the foundation for the surgical session, it is the thing that provides medical necessity for you being there. You'll want to make sure that you're as complete as possible according to the ICD-10 guidelines in the description of the diagnosis on the anesthesia record, remembering that rule out or possible are not sufficient descriptions for a diagnosis. You need to stay away from those terms. Also, status post is not sufficient for primary diagnosis descriptions, though it can be used as a secondary diagnosis description. And finally, when it comes to diagnosis, we're mainly looking for the post-op diagnosis, not just the pre-op, but mainly the post-op. Let's shift to time. Remember that you're being paid not just on the base units that are associated with these anesthesia codes, but also for time units. Typically, most payers will pay you one time unit for every 15 minutes. So what is anesthesia time? According to the government's own definition, it's that period during which an anesthesia practitioner is present with the patient. It starts when the anesthesia practitioner begins to prepare the patient for anesthesia services in the operating room or equivalent area. That's start time. And it ends when the anesthesia practitioner is no longer furnishing anesthesia services to the patient. That is, when the patient may be placed safely under postoperative care. So your stop time is the same thing as your care transfer time when you turn the patient over to the PACU nurse or the ICU personnel. So a good way to support your claimed stop time, let's say it's 9:30 listed in the stop box of the anesthesia record, is to drop a note below that says 0930-care transfer. So there you are using the government's own definition of stop time to support what you did at 9:30. As far as supporting your start time, remember that the anesthesia specialty has historically said that once you enter the OR with the patient, the anesthesia clock can run. Across the payer spectrum, that is certainly an acceptable default position for start time. Occasionally, you can start your time before the pre-op, that is before you enter the OR, if you are adhering to the definition that the government laid out in the previous slide for what start time is. And again, that's when you begin to prepare the patient for anesthesia services. That may begin, according to many experts in this area, such as compliance attorneys, it may begin in the pre-op holding area if you are doing something that helps to prepare the patient for anesthesia care. For instance, let's say nobody in the PHA can start the IV through which the anesthetic is going to be infused, so they ask you to do it. When you place that IV, you're helping to prepare the patient for anesthesia services. So you could begin your time there, but remember that once you walk away from the patient, you must stop the anesthesia clock. And then when you go back into the OR with the patient, then you can start the clock again. Remember that time does not start with things such as patient ID, chart review, the pre-op assessment, or sedation for a preoperatively placed post-op pain block. Other time issues. So invasive lines and nerve blocks are separately payable as surgical procedures. Now, if they're performed after start time, but prior to induction of the primary anesthetic, the time it takes you to place those blocks or lines must be deducted. So please make sure to document the placement start time, the placement stop time, and the time of induction of the primary anesthetic. If it's a handoff situation where the case is being handed off to someone else, that second provider to whom the case is being handed off needs to sign in on the record because they're providing intraoperative care, and they should also provide the time that they came in on the case. So relief time should be documented by the relieving provider. And then finally, remember not to list both start and stop times always only in 5-minute increments. Medicare is looking out for that. That's considered a deficiency. So if the start time is 8:36, list 8:36 as your start time, not 8:35. You don't want to round up or round down to the next nearest 5-minute increment. Now, there are different models that groups will use across the nation. It may be that in your facility, you only have doctors. If so, then that's a personally performed case signified by the AA modifier appended to the anesthesia code on the claim form. But if you're medically directing, then the doctor's claim will have a QY on the claim form if they're only medically directing one CRNA. Now, if they're medically directing 2 to 4 CRNAs, then QK will appear on each of those claim forms for the medically directing doctor. If the physician is medically directing more than 4 CRNAs, then the AD modifier would be added to those 5 or more cases. That means that you've been downgraded, doctor, to 3 base units only for each of those cases, assuming they're all Medicare cases. And you do have a shot at getting 1 time unit for each of the cases if you can show documentation on all those cases that you were present for induction on those cases. So the most you could get is 4 units for each of the 5 or more cases. The CRNA would continue to get the 50% to which they were normally entitled. Now, a CRNA's claim form, if they're medically directed, will have a QX modifier, and a CRNA who is non-medically directed would have a QZ modifier entitling the CRNA to 100% of the allowable on the case. Concurrency is determined based on the number of cases being medically directed at any one moment. And we have a concurrency module that monitors these case counts. Now, if you're medically directing, there are 7 things that you must do. And this is a look at the 7. For instance, you have to personally perform the pre-anesthetic exam. You have to prescribe the plan. There are several things that you have to do here. I'm not going to go through all 7. We'll take a look at these in more detail in the next slide. But I want you to notice that little box on the far bottom right-hand corner. And you'll notice that these are entitled the exceptions. So these are the acceptable exceptions to medical direction. These are the things that CMS National says that you can do while medically directing, doctor, and it not negatively affect your medical direction status. These will not add to your case count. Let's say you're medically directing 4 and you don't want to hit that 5th case because that means lower reimbursement, right? And so you don't want to pick up a 5th case. Well, doing these 6 things here in this box will not cause you to pick up that extra case. So, for instance, you can address an emergency of short duration. You can administer a labor epidural. You can check periodically on that laboring patient. You can receive patients entering the OR suite. You can check on discharging patients in the PACU and handle scheduling matters. So those are the 6 things that are enumerated by CMS National. The question is, can you do more than that? Are these illustrative, or are they exhaustive? Can you do these and these only? Well, that question has been put to all the medical directors of all the Medicare administrative contractors throughout the country over the years. And basically, they have come back to say universally at this point that you can perform things such as a post-op pain block or place an invasive line, take a short lunch or bathroom break. As long as you remain immediately available to address emergencies, then these are the kinds of things that will not affect negatively your medical direction status. Now, what do you have to document? You have to perform all 7 of the things we saw on the previous slide, but you need to document specifically, especially for our purposes, on the anesthesia record, the following: that you were present for induction, present for emergence, and that you monitored some portion of the case. Now, for a MAC case, for instance, induction and emergence is not going to apply, but for a general anesthetic, that will apply. So you need to have attestation statements: present for induction, present for emergence, monitored some portion. Now, if you're in a practice that has residents or SRNAs, let's take a look at some of the teaching rules. If you are one anesthesiologist working with one resident, then the anesthesiologist is paid at 100% of the allowable. If it's one anesthesiologist involved with 2 resident cases simultaneously, again, you get paid on each of those cases, doctor, at 100% of the allowable for each case. If you are teaching one resident case and you've got one CRNA that you're medically directing in another room, then again, you're paid 100% for the resident case, 50% of the allowable for the CRNA case, while the CRNA is paid the normal 50% on their claim form. Now, the teaching provider must document the following: present for key events, including, where applicable, induction and emergence, and they need to attest that they remained immediately available. If SRNA cases are involved, then here's the breakdown on that. If it's an anesthesiologist working with one SRNA, the anesthesiologist is paid 50% if medically directing that SRNA. The SRNA, there's no payment for that part, so it's a 50% only situation. But if the anesthesiologist is continually present in the room with the SRNA throughout the case, then of course it's 100% reimbursement, because it's almost as if you're personally performing and the SRNA is simply in the room with you. But you must, in order to get paid at that rate, you must document continuously involved, if in fact you were. Now, if it's one anesthesiologist working with two SRNAs, you're basically medically directing those SRNAs and you get paid 50% on each case. However, if it's one anesthesiologist, let's say up to 4 SRNA rooms, but each room has a CRNA in the room, then you're basically medically directing the CRNAs who simply have SRNAs in the room. So at that point, both the anesthesiologist and CRNA will get paid 50% on each case for each claim. If it's a CRNA who's teaching, and they're teaching either 1 or 2 SRNAs, they get paid 100% in each scenario for each case. And finally, if an SRNA is the one who does some type of flat fee procedure, we've had many Medicare administrative contractor jurisdictions tell us that the teaching physician or teaching CRNA can get paid for those flat fee procedures performed by the SRNA, but you must document that you were present during the entire placement of that line or the entire placement of that post-op pain block. Now, when it comes to post-op pain blocks, we're looking for this type of documentation. We need to know the provider who performed it. We can't assume it was the attending on the case. It might have been your partner. We need to know the details of the procedure, such as what type of block was it? Was it a single shot block or a continuous catheter? What was the location of the block? And anatomically, that is. And then confirmation that the block was performed at the request of the surgeon. So the magic language we're looking for here is at surgeon's request. Again, quote, at surgeon's request, end quote, is what type of verbiage we're looking for in your block note. And then also confirmation that the block was performed for post-op pain. It wasn't used either as the primary mode of anesthesia or to supplement the primary mode of anesthesia. It needs to be obvious to the coder and to the auditor that this was used only for post-op pain. Now, these blocks that you see here on the screen are sometimes performed. We do not yet have a CPT code that reflects these services, so we send these in on a claim form with the unlisted block code, and sometimes they're paid, sometimes they're not, but just be aware that there's no guarantee of payment. For 2023, we have a new rule that will bundle ultrasound guidance into these codes that you see on the screen. It used to be, last year that you could bill both these codes and the ultrasound guidance code, but now ultrasound guidance is bundled into these codes. So they're worth a little bit more than the codes last year, but they are worth a little bit less if you counted both the code and the USG from last year. As far as rounding on these blocks, remember that the round must be a post-op pain round. It's not the post-anesthesia round, so it has to be distinct from that. And as far as documentation requirements, if you're rounding on an epidural catheter that's indwelling, then you'll want to make sure that you denote that the catheter is still in place at the time of the round. And you'll want to mention something about how you manage the epidural. As far as any other type of pain round, such as a femoral catheter or yesterday's Duramorph injection, then you're going to be wanting to document an evaluation and management service, specifically a subsequent hospital care service. It's sort of like a doctor visit that you're documenting, where you're documenting things such as a history, an exam, remembering that the level that will be billed out is going to be based on the medical decision making or total time. Typically, we're looking at a low-level subsequent hospital care code for these types of rounds. For the epidural catheter round, that's going to be worth a little bit more using the daily pain round code 01996. Now, for invasive lines, again, these are separately payable as long as you actually place them and not just monitor them. So you'll want to make sure you document the placement. Obviously, tell us which line was placed, who placed it. Was it you? Was it the CRNA? Was it a partner? We can't assume it's the attending. And if you're doing a swan that's floated through a central line introducer, we can only bill for the swan, not the introducer. But if you use a second central line in a separate anatomical location, make sure to let us know that by means of verbiage such as second stick, to make sure the coders will get you paid for that second central line along with the swan. Now, when it comes to USG for these lines and blocks that we've been talking about, except for where they're bundled now, then you are required to retain in the patient's record both the image and the report if you want to get paid. So that means we at the billing office need evidence that you did in fact retain the image and report. So if you'll just make sure to attest on the record where you're making a claim for USG, such as image retained, that kind of verbiage is necessary for us at the billing office. That'll help check off that requirement box, image retained, if in fact it was. And then for the USG report language, we've given you some examples here. For instance, if it's a USG report for block placement, then something like, quote, USG used to guide needle, view medication diffusion, end quote, something like that will help to suffice for the language requirement that we have here at the billing office. If you're doing TEEs, or as I call them for short, Ts, much easier to say, Medicare will only pay for diagnostic Ts, and that even goes for the where you only did a probe placement. It has to be a diagnostic T probe placement that gets you paid. If the T was placed only for intraoperative monitoring, that's not payable to Medicare or the majority of other carriers. And so you'll want to make sure that you're documenting what type of T service you performed, i.e., did you do the placement only, the interpretation only, or both, because that involves 3 separate codes. And was it in fact diagnostic or not? If it was diagnostic, use the term diagnostic. Or if it was for intraoperative monitoring, state that as well so that we can be clear on which code applies. Now, one way to determine whether or not it was diagnostic is if somebody did an interpretive study and completed a formal report. Somebody had to have done that for it to be diagnostic. So if you were the one who did the report, then send that in to us as well. If it was someone else, like the cardiologist or your partner, then that's fine. You don't have to send in the report. Now, also, we want you to document any other additional T modalities used, such as pulse continuous wave or color flow, Doppler, 3D, because that provides different codes and additional monies. For code 93355, you see the descriptor there. TAVR is one of the acronyms used for this service. If you're doing something like this, then this code involves the following issues such as real-time image acquisition and documentation. It has to be a diagnostic T, as you see, and it does bundle the ultrasound contrast, Doppler, color flow, and 3D. Now, this, in order to get paid, must be performed by a provider who is not also administering the anesthesia for the case. So let's say your partner is the attending, but you are the one doing the T service only intraoperatively, then you can get paid for that service, but there must be someone else doing the main anesthesia service. Beginning last year, we had a new code 93319, which is an add-on code. And you can see that that has to do with 3D echocardiographic imaging and post-processing. And so if this is something that you're doing, this is the code for it. Now, for unique circumstances, they can be paid additional units on the claim form. At least some payers will do this for you. For instance, some payers will pay an additional unit if the patient is under 1 year old or over 70. Some will pay you 2 units if it's an emergency. And of course, you need to document what the emergency was, remembering that it exists when there is a delay in treatment that could lead to a significant increase in the threat to life or limb. So you want to jump on that quickly so there is no such delay. That's an emergency. Document those circumstances. Some payers will pay you extra for that. Field avoidance is almost never payable. Very few payers will pay for this, and the circumstances in which you can get paid are very minimal. It only pays a total of 5 base units, not extra 5, but total 5. So you would only use this where the code would have paid you either 3 or 4 units to begin with to get you up to that 5. If you're doing something that pays you 7 base units normally, then field avoidance will not help you in any way as from a financial standpoint. Remember, the field avoidance exists where there is limited airway access. So document that circumstance, limited airway access, if you think that field avoidance will help you with extra reimbursement. Now, these are the kinds of cases that require even further attention to your documentation. So let's go through each of those in turn. For endoscopy, it could be anywhere from 3 to 6 base units, depending on what happened in the endoscopy session and which of the components you actually documented. The codes on the left are the endoscopy codes. The numbers in parentheses are the base unit values. So you can see there's a range there. Was it upper GI or lower or both? Did ERCP get mentioned, et cetera? So you can see that you have to get your facts down in your documentation to get us to the right code for you. Now, if it's a screening colonoscopy for Medicare, that's going to implicate code 00812. That tells Medicare the patient owes nothing. No copay, no deductible. But if there is some type of intervention performed, then that knocks the code down to 00811, telling Medicare, now the patient owes a copay. And so you'll want to make sure that you document things such as the intervention. If it's a biopsy or a polypectomy or any other intervention, that's the key thing you want to document in screening colonoscopy. So to sum it all up, in your documentation of endoscopy, let us know whether it was upper or lower or both, whether or not ERCP was mentioned, whether or not it was scheduled as a screening colonoscopy, any interventions performed. And unlike all other types of anesthesia cases where we're looking for the post-op diagnosis, here for colonoscopies, we're also needing the pre-op diagnosis. And by the way, these are acceptable descriptions for pre-op diagnoses that support screening colonoscopies. Those are the descriptors you see there. Now, for chronic pain services, where you're being asked to provide the anesthesia coverage for what the chronic pain doc is doing. Let's say he or she is doing an epidural steroid injection, an ESI, and they want you to come in and provide the anesthesia because this patient has some issues and may panic or may need a general, or maybe they're young, or maybe they have a history of problems. So they ask you to do the anesthesia. Remember that payers don't want to pay for this. They don't want to pay you for providing the anesthesia. So The threshold to get paid on these as an anesthesia provider is quite high. So you'll want to make sure that you document all patient comorbidities. Make sure it's a patient status of 3 or more. Where that is the case, that you document why that's the case. Anything like that to help support the medical necessity of you being there and getting paid will be helpful. Now, notice all the possible anesthesia codes. I think there are 8 listed here. So you'll want to make sure that in your documentation, you list the correct components of what happened. And so in your documentation, you'll want to list the name of the block that the pain doc performed, the positioning of the patient, because this will, depending on the positioning, it may be a different code, whether or not fluoroscopy was used, and again, all the comorbidities and patient status support that you can list that help you get paid. Now, for labor epidurals, that's code 01967. This is not the same as a normal anesthesia case. Medicare doesn't even make a determination as to whether this is an anesthesia case. They leave it up to each individual facility to determine whether or not it's anesthesia or analgesia. And so because it's a different animal, the billing rules are different for this type of case, and there's no national standard. Where there is no payer requirements already published, then we recommend one of the options found in the ASA's relative value guide, namely billing stick to delivery subject to a reasonable cap. As far as the labor epidural time, we recommend billing stick to delivery subject to a reasonable financial cap. That means you'll want to document the insertion time, that's your start time, the insertion of the epidural needle, that's your start time. Your stop time would be the delivery of the infant or any other post-delivery event, such as delivery of the placenta or episiotomy repair where the epidural is still in place. That can be your stop time. And then also remember that the diagnosis should indicate the length of gestation and the outcome of delivery. Sometimes we come across hybrid cases where the insurance plan has made clear that we're going to pay for part of the case, but not the cosmetic portion. If that's the case, make sure that you are documenting the time parameters for the cosmetic portion of the case. I've given you an example. Quote, cosmetic procedure dash 1233 to 1308, end quote. Something like that to allow us to carve out those minutes from total anesthesia time so that we are not improperly submitting that time to the payer. And then for canceled cases, sometimes you can get paid on these. If the case is canceled after induction, you can bill the full base and time minutes reflecting the time you're on the case. Make sure you send in the anesthesia record, letting us know, A, that the case was canceled, B, why it was canceled, and C, when it was canceled. If the case is canceled before induction, and you've already performed the pre-anesthesia assessment, that assessment is typically bundled into the base units of the anesthesia code. But if there's no anesthesia case that happens because it was canceled, but you did do the pre-anesthesia assessment, now we can unbundle that and get you paid separately for it. If you wish to submit that, then send in the pre-anesthesia assessment along with an explanation as to what happened, and we can see about getting you paid for that. Now, for incomplete colonoscopies, we simply need for you to document the extent the scope reached, whether it was prior to the splenic flexure, to or beyond it, but not to the cecum, or was it to the cecum. And finally, we have a system of communicating with our clients where we are not able to clarify some of the information on the record. Maybe something is omitted, or there's a contradiction, or there's confusion. In that case, if we cannot determine through our own methods of finding out the information, for instance, by going through the hospital portal and taking a look at the surgeon's report, then we will communicate with you, typically by way of email, asking for your clarification. These are called information requests. Sometimes they're called provider returns. And we just ask that you respond to such communication within 48 hours, if at all possible. So to recap, providers are expected to know and comply with the billing and documentation rules. Remember that our claims are only as complete and accurate as your documentation. Remember also that you are the one responsible for the claims that are sent out in your name. So if you've got great documentation of the record, then chances are the claim is going to be filled out properly in your name and thereby avoid hassles from auditors or government entities. And I do believe that working together, we can increase the odds of quick and accurate claim submission. If you have a question about anything that we've covered in this presentation, please don't hesitate to contact me. You see my email address there and my cell number. Look forward to talking with you. Thank you so much for your attention and have a great day.